applications. We have a full array of senior adult services at the JCC. Many of you I see are friends of ours and are members and attend our programs. And I just want to welcome you here, as well as all of everyone else who's come on to learn a variety of senior options from some what I would call real experts in the field of aging. I will direct you, if you can, to our website, because there are other programs that we are providing. We have caregiver services, we have support services, we have social programs. So we have programs for Parkinson's and for dementia. So make sure to check out our website when you get off of here, and you'll see lots and lots of wonderful programs and webinars and presentations. This program is being recorded. So if you have friends, neighbors who would benefit from this information, please direct them to our website where the recording will be. So without further ado, I want to introduce our panel. We are going to start with Jennifer Devine, who is the Director of Caring People, a home care agency that we work closely with. And I am very proud and pleased to be able to have Jen present today. Jennifer Devine is a licensed social worker. She's been working with Caring People, a licensed home care agency, for 13 years. Prior to that, she worked in a hospital and skilled care facility. She is honored to work with the senior population. And so, Jennifer, why don't you begin?
Hi, everyone. So thank you for having me, and thank you to the JCC team for organizing this event tonight. I'm going to be talking about the various home care options that are available to you. So we're going to start with certified home health agencies. Most people like this one because it is covered by insurance. So that's always a plus. You may hear people in the healthcare industry use the term CHA. You'll probably hear me use that a lot tonight because I'm just so used to it. So one is eligible for certified home care services if they have a skilled need, coupled with having a difficult and taxing time leaving their home. So a skill need could include needing wound care, physical therapy, occupational therapy, or speech therapy. And one is allowed to leave their home to go to medical appointments and places of worship. I think even hair appointments count. You just can't go to parties or happy hours. They tend to frown upon that, at least for eligibility reasons. So a medical doctor would need to write a prescription for services. And then typically a RN or a physical therapist from the CHA would come to the home and evaluate you for eligibility and to let you know what services that you could get. CHAs are made up of interdisciplinary teams, and that includes RNs, physical therapists, occupational therapists, home health aides, and social work. Which of course, being a social worker, I often say is the most favorite team member on your CHA. It is limited and it is short term. So you do have the right to choose a provider of choice. There are many, many certified home care agencies here in Long Island. And I would say 2 takeaways to put in your notebook if you're taking notes tonight. Is that you do not have to wait to be hospitalized or go into a rehab to be eligible to get these services. You can be in the community and your primary care doctor can order them for you. We encourage our clients to take advantage of this because in some cases, it can prevent hospitalizations, and we have had that experience for our clients. The second takeaway is that you cannot receive home health aid services exclusively through a CHA. It has to be in addition to a skilled service. So the amount of hours that one would receive while on a CHA is very limited. So therefore, people often will use a licensed agency in conjunction with a CHA. And then we will go on to the licensed home care services now. So licensed home care service agencies are also referred to as LCSWS. You will hear that among healthcare providers. Most CHAs have contracts with licensed agencies. Therefore, someone could do what's called split billing if they work with two agencies that have contracts with each other. An example is a CHA approves 2 hours of a home health aide, but you know that you might need 8 hours. So you would pay for 6, and the other 2 is billed to Medicare. So that we often recommend working that way when possible. Licensed home care services are paid privately by long-term care insurance, catastrophic insurance, and through Medicaid. There are some life insurance policies that have a home care benefit that you can tap into. Licensed home care can vary in the services that they offer, but the one thing that they have in common is home health aid services. Home health aides can perform hands-on care. It's often referred to activities of daily living. That's a term that you would hear a lot. And what that means and includes is things such as toileting, transferring someone, showering someone, someone who might be incontinent, caring for them. They can also do basic vitals along with household duties. And they are all supervised by registered nurses under a licensed home care agency. And many licensed agencies offer services such as medication management, skilled nursing care, and something called care management, which my colleague will be talking a little bit more about. Licensed agencies are supervised by Department of Health. And then the next one that we're going to be talking about is companion care. So companion care is non-medical, or some people refer to it as non-hands-on care. They tend to work with what they call a more able-bodied population because of this. And their focus is really on quality of life, as all home care is. But they're focusing on socialization, meal prep, driving, light housekeeping, and shopping. Sometimes people will wind up starting with this level of care, and then they bump it up to licensed home care as their needs increase. And we've also seen it go the other way, especially with our orthopedic clients. They'll start with us, and as they continue to improve, they will go down to companion care. Something that Caring People offers also is cultured companions. And my colleague Anne might touch a little bit about that as well when she talks about the care management. But that's really focusing on people who have, they're missing going to the arts and to the theater and different things like that. And in fact, some of these companions that's what they do. They will take them to the arts and to the theater. So a company that strictly does companion care is not going to be regulated by Department of Health. And then we're going to talk about independent contractors. So licensed home care, I believe, working for one for 13 years, it has so many benefits, but of course it does come, the reality of it is that it does come with a price. And some people just cannot afford that. And when I go and meet with a client, a family, and I see that they cannot afford it, we will often begin talking about independent contractors. So there are referral services that for a fee will help you to find an independent contractor. And an independent contractor is not affiliated with an agency. They should absolutely cost less than what you would be paying to a licensed home care agency. There could be less restrictions, or there is less restrictions in what type of care they will provide. But you are responsible for paying for the caregiver. You're responsible for managing the oversight. And if you want a background check on them, you would be responsible for getting that background check. Although I did have an interview today with a referral service, and she happens to do background checks on all of her independent contractors. So that was a nice find. But we do always recommend consulting with your attorney, and I happen to know a very good one on this panel. or your accountant whenever you're hiring an independent contractor. And now I'm going to hand it over to Anne, who's just going to talk a little bit about care management.
Sorry about that. Hi, everyone. Good to be here. Brings me back to my JCC days when I worked at the Mid-Island Y many moons ago. But I've been doing this aging consulting, if you will, for over 20 years. And I'm with Caring People, recent merger. And I'm happy to be with them. It's a great combination of the home care and care management. So what is care management? I'm going to go a little bit off the slide for a second and tell you that about 35, 36 years ago, there was nothing like care management. And care management is used a lot for different professions. And my organization, the Aging Life Care Association, changed the name because care managers were used so frequently and different kinds of ways. So what happened was people would leave hospitals and still need help or need various help. So they called the good social workers in the facilities that they just were discharged from because they couldn't get the medications or they couldn't get through their home that they couldn't manage or they couldn't write bills, various issues. And the social workers started to take on these kind of jobs, if you will, and created, at the time, Care Management Association. And there were many throughout the country and here on Long Island. I look at us as aging experts. We're independent professionals, and we will be the quarterback, if you will, if in this football season, good analogy, of really digging deep and, as it says on the slide, creating a care plan based on an assessment, a holistic assessment. And that is everything from safety of the home, family dynamic, the activities of daily living that Jen mentioned before, walking, bathing, eating, dressing, transferring, what you would need help with, what you can do independently. That's always our, we want to keep people as independent as possible, but if they need a little help to get through or to strengthen, it's better than waiting and not getting help and having things kind of go south a little bit. And certainly programs like the JCC provides helps with that as well. So we look at all of that, plus financial, legal, referring attorneys, referring anything that's needed, whether it's a chairlift, safety of the home, really a holistic view, social, spiritual. We find so often that our socialization and connection to culture, or people who used to go to synagogue or church and now they don't because they can't get there. That's a big part of life. And we kind of let that slide a little as we do age. We advocate for people in all settings, whether they're at home, in a facility, in a nursing home, hospital. We try to keep people out of hospitals, but sometimes it's unavoidable, and we will advocate at doctors' offices for ongoing, what we call ongoing care management. We will go to the doctors or telehealth, whatever is happening at the time. We will communicate with family or whoever is helping that person or part of their lives, and help provide the information to make good decisions, whether it's medical, place where they should live. Again, this is we look at the whole person and their environment. Helping families adjust to new realities all the time. There's a lot of things happening in the aging process that people don't want to see. Denial is the big river. And, we're there to kind of have people look at things the way they are, and to accept it, and to, again, make the better decisions based on the good information. There's always changes with anybody, if you, no matter how old you are, we're always going to have some changes, and we want to catch or look for those changes just before things get out of hand. We have a great program at Caring People, Just Checking, for those who are well and aging pretty well and don't need that, really intense care management of going to the doctor all the time, or checking in, or helping with their support system of home health aides or companions. And we can check in on people, visual of once a month and telephone calls twice a month. And we're looking for those changes. We're looking for maybe mail piling up in the corner, or something that's different about the person that we notice as aging experts. And we bring it to their attention and get the help again before things kind of blow up, or before any crisis or any hospitalization. It's a really great program, and it's definitely value-based, as everything we do. Again, I mentioned before, we manage home health aides. We help with just making sure you have the right level, as Jen mentioned before, and what what's out there for you. Unfortunately, we live in a society that isn't as forthcoming, which is why all the panelists here do what they do and help people. And on Long Island, we have a great network of professionals that, again, I've been involved with for over 20 years. And I mentioned before, we try to avoid the crises, but if there is a crisis, and usually those are the calls we get, whatever level crisis that is, but we're available 24/7 for our clients. And even for the just checking, that, again, we try to avoid that. We put in the interventions, the resources we know, to help with keeping people at a better quality of life than before they knew us. And if there is a crisis, we go, no matter what time of day it is. I think that's it for me. Thank you.
Okay, thank you, Jennifer. Thank you, Anne. Appreciate that. So now we're going to move on to Julie Wexler, who's the Director of Business Development for the Bristal Assisted Living and a Friedberg friend. Julie has dedicated her 25-year career to supporting and enhancing quality of life for older adults. She has worked in an array of settings, including government-funded senior centers, the New York City Department for the Aging, adult daycare programs, and in senior living for the past 8 years. She's dedicated to ensuring that all older adults, regardless of advancing age, live healthy, active, purposeful, meaningful, and social lives. Thank you, Julie.
Thank you. It's such a pleasure to be here this evening. I just want to thank you, Gloria and Pam and Stacy, for setting all this up. I'm just letting you know that I am doing this from home, and my little fur baby is actually right there, but my husband is going to be home very soon, and he will let me know when that happens. So I profusely apologize if there's some background noise. Let's see if we can get through this. All right. So I'm going to talk to you today about the alphabet soup, if you will, of different senior living options. But first, I really want to kind of set a precedent for why we're even talking about this, right? Why are we even having this presentation today? So we know that the 65 and over and the 85 and over demographic is the fastest growing demographic, not only in the United States, but here in Nassau and Suffolk County. And these statistics are really phenomenal, that in Nassau and Suffolk County, in the last 10 years, there has been over a 50% increase in these populations. This has tremendous implications on our healthcare system, on the existing housing stock, on really how we support older adults who are living, in our neighborhood. So we also know that many of the homes that were built and purchased in the 1950s, 60s, and 70s sometimes are not conducive for people to be able to age safely in them. There certainly are plenty of wonderful companies out there that can help do modifications for your home, but it might be the choice for an older adult to not do that and maybe move to a safer, more stimulating, more social, more supportive environment in their older years. We also know that especially here on Long Island, that we have an automobile-based form of transportation. So for many older adults who are no longer driving, unable to drive, this can really be a hindrance on their independence. So just a couple of things to think about. We also know that as we age, the studies show over and over again that folks who are more social, that have more structure and have more opportunities for social engagement, really age better. They live better, they have better health outcomes, and generally have a better quality of life. All right, so we're going to talk a little bit about when it is time to move, right? I wish I had that perfect answer for you. I don't have that perfect answer for you. This is a very, very individual question answer for everybody. But some things to consider. So at the Bristal, very often when people call us and start inquiring about different senior living options, it's because there might be some sort of a decline in health where they are no longer able to drive. We know that there are vision deficits. We know that our reflexes don't work as quickly, or there might be some sort of memory impairment. So being no longer able to drive might be the time to start thinking about moving from the home. Perhaps there's a cognitive decline. This is a very uncomfortable conversation for people to have, but we cannot have this conversation when we're talking about the aging population without talking about cognitive and physical and cognitive decline or a dementia, memory loss. So we know that by the time you are 65, there is a 1 in 2 chance of having memory impairment. By the time you're 85, it's 1 in 2. With the average life expectancy in the mid to upper 80s, it's really a conversation that we're going to have, because there's a chance it's not only going to happen to us, but it could happen to our loved ones. It could happen to ourselves, and we need to have these conversations with our families. Perhaps there's increased social isolation. Could be the death of a spouse, could be friends that are moving away. Perhaps there's a history of not eating well or a history of dehydration. So we know that, when you're eating a meal, it's not just the nutrition and the calories that you're taking in, but, meals are social activities as well. So when people are living alone, it's not uncommon for people not to eat the right kinds of foods to keep them healthy, or to drink enough water to keep them hydrated. Perhaps there's medication errors or increased health concerns. Perhaps a history of falls. Maybe it's caregiver burnout. Very often, if there is a dementia diagnosis and it's a husband and wife situation, we know that it could be a tremendous burden on the well spouse. Maybe it's time to consider moving to a more supportive environment where the spouse who has the dementia or the health concern can get the support that they need, and the well spouse can live a little bit more independently without having to worry about the burden of caregiving as well as managing the house. Perhaps the home is no longer safe or accessible. As I mentioned before, many of the homes that were built decades ago, we have the stoop going up to the front door, we have the laundry in the basement, maybe doorways that aren't wide enough, or bathrooms that are not handicap accessible. Perhaps the home is no longer safe. Perhaps you just want to be proactive, right? Always better to make a move when you're feeling healthy, when you can be part of the decision-making process, when you can work with your loved ones, your family, your adult children to find that perfect place just for you, right? Or maybe I wrote here, your kids are bugging the heck out of you, right? They're doing it because they love you and because they want you to be safe and happy. All right, so we're going to talk a little bit about what the options are for senior living, right? Care at home. Thank you, Jennifer and Anne. It's always an honor to be on a panel with you. You're going to hear from a wonderful attorney after me who's going to talk to you about how we're going to pay for all this stuff and how we can plan proactively to make sure that we live with the dignity and the security that we all deserve. I'm going to open up the door to let the little fur baby out. Okay, sorry about that. All right, so we know we have care at home. Thank you, Jennifer, for that presentation to really get us to a point where we can kind of understand the continuum of the different home care options. Right, so we know that there are many 55 and over communities popping up all over Long Island. And this is because of that demographic shift that we were talking about before, of that 65 and over and that 85 and over aging demographic being that fastest growing demographic. So the 55 and over communities could be a rental community, it could be a purchase community, they could be apartments, they could be townhouses, but typically, they're going to be a little bit smaller than your family house, so it's a little bit more for you to manage, usually on one level. And you also have usually a clubhouse or maybe some organized activities, being around your peers. So there definitely are some pluses to being in a 55 and over community. What is an independent senior living community? So an independent senior living community, and actually the Bristal has a sister community called Encore Luxury Living, which is actually located in Jericho, sort of that next step. So I think of it almost like living on a cruise, where you're living in your own apartment. You have an apartment with a full kitchen, but there are amenities, lifestyle amenities, to help you live as independently as possible. So the independent senior living community might offer meals, usually it's 2 meals a day. You're going to get some housekeeping, you're going to get some organized activities, but you're generally living independently. But there might be a concierge. So there's just a little bit of support to help you age safely. If the time ever comes that you need any kind of assistance with taking a shower or getting dressed, you can hire your own agency. Some independent senior living communities might even have a home care agency already in the building to provide those kinds of services for you. The independent senior living communities are not regulated by the New York State Department of Health. If you have long-term care insurance, it will not cover the cost of independent senior living because it's not a licensed facility, but it will pay for any home care that you might need if you're living in the independent senior living community. So the next step, assisted living, and that's where the Bristal falls in, is assisted living. So these are, once again, apartment style living. You're going to have your own space. You're going to benefit from the structure, from having your peers around, from having organized activities, meals, 24-hour security in the building. And you're also going to have what we call a wellness team. So this is typically a team of personal care aides overseen by a nurse who can offer, if you need it, personal care assistance, showering assistance, dressing assistance, grooming assistance, medication management, even escorting, things like that. If you have significant memory loss where you need a smaller, more structured environment, many assisted living communities, including the Bristal, have a neighborhood within the building called, well, we call it Reflections. And Reflections has specially trained staff. It's a smaller environment for people who need that kind of support. So, about that, my husband just got home. Okay, so now we're going to talk about rehab. So what happens is you might have an illness, and then you're recovering from that illness, or you get discharged from the hospital, and you need a little bit of time to get stronger and better. So you're going to go to a rehab. And I put all this in the same bullet: skilled nursing, rehab, nursing home, long-term care facility, because they're all kind of the same thing. But the rehab is, you think of as a short term, right? So in Medicare, your insurance, your health insurance is going to pay for you to be in the rehab. But perhaps you need 24-hour skilled supervision. Then the skilled nursing facility might be the next step for you. In the assisted living world, many of us now have what's called the enhanced assisted living license, which is really an effort on the part of the state to keep people in assisted living, to provide a pretty high level of care so that people can age in place. So our goal in assisted living is for people to be able to stay there for as long as possible. And we can do a lot of things now in assisted living that we weren't able to do even 10 years ago. Things like assistance if you're in a wheelchair, Hoyer lifts, Puree diets, things like that. So it's really an opportunity if you're in assisted living. And these are good questions for you to ask. When will I have to leave? How long can I stay at the assisted living? For many assisted livings, we don't have a crystal ball. We don't know if you ever would have to go to a skilled nursing facility, but our goal is to keep you as long as possible. So the skilled nursing facility is going to be more of a medical kind of environment. You're going to have, 24-hour nursing. It's not an apartment. It's more of like a clinical or hospital type setting. But if that's the level of care you need, then you would go to a skilled nursing facility or a nursing home. A continuing care retirement community combines many of these levels of care onto one campus. So you might have the independent living, the assisted living, the memory care, and the skilled nursing all on one campus. There are not too many of them on Long Island. I think there's like 3 or 4. But the continuing care retirement community can be a good option for some people. What happens is use a very large down payment or entrance fee, if you will, in exchange for a lower monthly rent for these different levels of care as you sort of progress through the levels of care. And much of your down payment is refundable when you leave. And that could be whether you move out or if you pass away, and then it might be refunded to your heirs. So it can be a good way for people to preserve assets. In terms of assisted living, like the Bristal, how do we pay for it? Most of the people who live in our communities at the Bristal are selling the family home, right? They purchased your home many years ago, and now you have the resources through the sale of the house to be able to afford assisted living or memory care. If you have long-term care insurance, if you were fortunate enough to have purchased it many years ago, hopefully you have a nice, generous policy. As long as you meet the requirements of that policy, which is usually having a dementia diagnosis or requiring assistance with at least 2 activities of daily living, like showering assistance or dressing assistance, and the long-term care insurance will pay for the cost of assisted living. There is also a benefit through the Veterans Administration that if you meet certain income guidelines and financial guidelines, you might be eligible for. It doesn't cover the whole thing, but it might cover, I think it's about $1,200, $1,300. Maybe it's a little more than that. That's for the surviving spouse, maybe about $1,700 or $1,800 for the veteran. If you're also the spouse of a veteran, or if the couple was living in the assisted living together, you might be eligible for that veteran's benefit. So that's always a good thing to ask about. So grandma's old age home, right? I try every day to change people's frame of reference of what assisted living is, right? Communities like ours did not exist 20 years ago. We have come a long way since grandma's old age home. This is actually a photograph of our beautiful Bristal in West Babylon. So you can see it's beautiful spaces to enjoy your day, to spend time with family and friends. So I really encourage you to just change the way that you're thinking about it. And at least go visit, go explore and see what the options are. This is another photograph of one of our beautiful communities. And yeah, listen, there's always a sense of downsizing. You're going to be living in maybe a 1-bedroom apartment, a studio, perhaps even a 2-bedroom apartment. But we have to remember that you're going to have access to all these wonderful other spaces that we have in our community: the dining room, the library, the cinema, the bistro. The entire building is really yours, right? You just sleep in your apartment, all right? So amenities to help you live really a carefree life. And yeah, we have 3 delicious meals a day and daily housekeeping, an emergency response system, customized care plan, a full calendar of events, everything under one roof, visiting physicians. But our best feature is always going to be that well-trained, supervised team of caring professionals who become like family. So yes, the Bristal builds beautiful buildings, but it's really the people inside that make the Bristal a really special place for people to live and to age. Once again, our beautiful Reflections neighborhood. So for somebody with more significant memory loss, you still have that sense of independence because you have your own private apartment, and we encourage families to furnish it, to bring things from home, artwork and pieces of furniture that were meaningful to this person, to make them feel safe. And to have those things around them that are familiar. But we have a team that goes through very, you always have to hire the right person, right? And then they go through very varied training in terms of communication skills and behavior management, and really just knowing how to provide supportive care so that each person feels safe and has a meaningful day. And all of our communities have this Reflections unit, including the Bristal and Northwood Mere. All right, so I know everyone is probably curious to know how we have gone through COVID-19. there's the fact of the matter is we were all affected. Everyone was, right? Even if you were living at home, you were affected, but certainly in senior living, we were affected as well. We had certainly have come a very long way since those days back in the spring, in March, April, and May. We even have communities, believe it or not, that were completely unaffected. We actually have buildings that never had a single case of the virus, but that wasn't the case for all of our communities. The fact of the matter is there are very stringent New York State Department of Health and CDC guidelines. It really affected every aspect of what we do in senior living. And all of these things combined really helped to control the virus. And we went months and months and months without a single case of the virus amongst our residents. And many of our communities still continue to be virus free. Just like everyone else, we're starting to notice a little bit of an uptick. That uptick is actually related to staff testing positive because staff are tested weekly and residents are tested every other week as well. Dining has changed. We pride ourselves very much at the Bristal in terms of our dining experience. It's different now. We have 2 people to a table. There are plexiglass dividers. But we really hope as much as we can kind of keep things as normal as possible and keep things at the level that people are expecting from our communities. Once we do have a positive case, we do have to shut down the dining, so the residents will eat their meals in their apartments until we can kind of get through that waiting period, which is, I believe, 2 weeks. Recreation, the days of 60 people in the bistro listening to entertainment, not having those these days, but we're still able to have small group activities. We're still able to show films in our cinema. We're still able to have our discussion groups and our crafts and our art activities, just smaller groups, right? So however crazy things are on the outside, life continues to happen inside our communities with social distancing, with masks, with housekeeping procedures. We're very excited. The hair salons reopened just a few weeks ago. Our doctors are still visiting for folks who utilize the doctors in our buildings. The toughest part of all of this has been the family visitation. It was actually completely shut down for many, many months. But now with some pretty strict protocols, and as long as the building it has no positive tests for 14 days, we can have family visitation. So we're super excited about that. Throughout all this, people have been continuing to move into our communities. The fact of the matter is people need care. And we just want to make sure that people realize that a really well-run community, we're doing what we can to keep our residents safe and healthy and as active as possible. Here's my contact information. So you're certainly welcome to reach out to me if you have any questions about what life looks like at any of our Bristal communities. And I just want to thank the JCC again, and Wendy and Jennifer and Anne for being on the panel with me today.
Thank you, Julie, so much. Much appreciated. Before we go to our last panelist, whoops, and there goes my earbud. I just want to let everyone know that we will take questions at the end. You are welcome to put them in chat. Certainly, if at the very end there are not too many questions, we can have people raise their hands, but we certainly would prefer if you can put it in the chat function. And I guess, Pam, you will read off the questions, if that would be okay. That'd be great. Okay, so I just want to introduce our final panelist. Last but definitely not least, another Friedberg friend, Wendy Goidell is the founder of the Goidel Law Group and Concierge Care Coordination, which is a holistic practice model integrating care needs with legal and financial planning. Her goal is to help clients to protect themselves, their loved ones, and their assets while funding good and essential care. Wendy is passionate about and an advocate for safe and successful aging in place. And I present Wendy Goidell to you.
Thank you, Gloria, and everybody else from the Friedberg JCC. I need all the friends I can get, so I appreciate it. I have to say, just before getting started, that absolute kudos to the JCC and Julie and the Bristal and all caring people for keeping people safe during this COVID-19 crisis. I can't imagine what that's been like for everybody, and everybody's pivoted and kept everybody safe as much as possible. So I think that's, that's a huge undertaking. So congratulations to all of you. And it's not over, but I know everybody's working together and as a team to continue to provide the best care possible for everyone, wherever it is that they are residing. And I think it would be fair to say that the goal of all of us here today, both the panelists, the people from the JCC who organized this, and everybody here who's listening and participating, is to promote safe and successful aging in place. And that's really, and Julie mentioned that term, so that's really preserving your ability to be able to reside in the residence of your choice for as long as possible, with or without care, in the least restrictive environment. And that home could be the home where you lived for decades and raised your kids, or maybe you downsized to a smaller home, or maybe an apartment, or maybe you moved in with a child or a family member, or like Julie mentioned, it could be independent living community like the Encore, it could be an assisted living community. All of that is the residence of your choice. And we want to make sure, all of us here tonight, that you can safely and successfully age wherever it is that you want to age, and keeping you out of more restrictive care facilities. So our goal is to keep people out of hospitals, out of rehabilitation facilities, and hopefully out of skilled nursing homes. But sometimes certain realities interfere, like I think Ann mentioned, and that might be the only resort. But hopefully if you're here tonight, you can stay home. So we want to make sure that if you need that care at home, and you want to get the assistance of caring people, or you want to move into one of the Bristol's wonderful communities, that you can pay for that. So we want to talk about the different, pay options, and that could be private pay options, or it could be tapping into the Medicaid program. So different payer sources will be there for different options. So again, I don't think that Caring People or the Bristal is going to say no if you want to write a check to them or have an ACH out of your account to pay for the wonderful services. So paying privately for companion care, home health care, or the wonderful programs and the room and board and assisted living is always an option. And then other options are in the Medicaid program, which we'll talk about. And tonight we're really going to talk about that the home care option, or the Medicaid assisted living program option. We'll go to the next slide. Okay, so some of this was already touched upon, so I'm just going to go through briefly. Obviously, the type of care will dictate the providers of that care. So it could all start with supervision and check-ins, socialization, which you can get at the JCC, obviously now virtually, but hopefully we'll go back to all in person. Personal care assistance, as Jennifer mentioned, with all the activities of daily living and instrumental activities of daily living up through medical care. And there are different payer sources for everything. Next slide. So I don't think you need, go back one. I don't think you need me to stand here before you tonight and tell you that care is expensive, but that's exactly what I'm doing. So there are obviously different average costs for different types of care. This is just some figures for different types of care. So we've talked about companions and home health aides. Some of our clients pay a lot more than what's on this slide. The day programs we've seen run from $60 to $75 a day in New York. Assisted living, obviously, this is just an average. And then the skilled nursing facilities can be at least $15,000 a month. So you can see how quickly, if you need, or your loved one needs significant care, how quickly you can spend down assets and become destitute. And we want to make sure that that doesn't happen, because we want you to be able to have options. We want you to be able to stay home, you and your spouse. If one spouse needs care and spends down all the assets, well, when you need care, there may be much fewer options. And so we want to be able to plan proactively, as Julie said, in advance of a crisis. And talk about how we protect assets and fund care. Next slide. So these are all the payer sources for care. So in all my years of practice, and there's a couple of other little ones that I'll mention, these are really the only sources. Other than this, I could tell you to go out and rob a bank, but I don't endorse that, or I'm not encouraging that. So I am an attorney. I don't practice in criminal law, so I'm not telling you to do that. So there are a lot of misconceptions, and a lot of people understandably use the terms Medicare and Medicaid interchangeably, but they're two distinct government benefit programs. So most of you may know that Medicare covers some short-term care, some short-term rehabilitation after a 3-day hospitalization. It'll pay up to the first 20 days in full, and then 20 days 21 to 100, there's a copay that's usually covered by your supplemental policy or Medigap policy. But Medicare does not cover long-term care. So it's something that you need to, if you're taking notes, just make sure you realize that. Julie mentioned private pay. Yes, so you could sell your home to fund your stay in assisted living, or you may have very high income, very high net worth, have a lot of assets, and you can self-insure. That's what we call self-insurance. You can pay for your own care. You know, if you have significant assets, you can pay for all of your living expenses plus your care needs, and perhaps never break the bank, and that's great. And sometimes people are medically ineligible for that long-term care insurance, so they are going to privately pay maybe for a while. Then we'll get into talk a little bit more about the long-term care insurance. That is a great option. I'll just tell you a quick anecdote. When about 15 years ago, I think it was, I'm talking to my son Mitchell in my kitchen, and all of a sudden he turns around and says to me, "Mom, when you turn 90, I'm putting you in a nursing home." I kid you not. And I go, "Really? What? Why, Mitchell? Why a nursing home? What if I'm a young 90? He goes, "Doesn't matter. I'm putting you in a nursing home." It's like, that's great. So not only did I turn to my daughter, Alex, and say, "You're getting everything now," I called my husband. I said, "We need to go out and get long-term care insurance." So I kid you not. So I got it at a young age. And I mean, that was an actual story, but that's not the only reason why I got it. But we can't rely on those good for nothing kids sometimes who bug the heck out of us, like Julie was talking about. So we got to be proactive, take the bull by the horns, and make sure that we're protected. Julie mentioned the Veterans Aid and Attendant benefits, which is a great way to obtain a cash stipend if you qualify for that. Then, you know, if we don't sell our home, but we want to live in our home, but we need to pay for care, we could look into getting a loan. It could be a conventional or a reverse mortgage. So we can tap into the equity in our home. I mean, it doesn't mean because you're 62 and Tom Selleck or whoever it is out there touting reverse mortgages says you have to get it. You don't need to get it just because you're a certain age, but it is an option in the right situation. So that's why it's always important to talk with your team of advisors, of accountants and attorneys and whatnot to look at all these options. And Medicaid is a payer of last resort. That's why I have it as the last bullet on the slide. And the Medicaid program we're going to talk about is the community Medicaid in a couple of minutes. So the long-term care insurance, I'm not a long-term care insurance advisor. I don't play it on TV. I don't sell policies. We just spot issues and we look at this. So we've got to, if you're relatively young and healthy, when I have clients coming into my office and they're relatively young and healthy, we will talk about this. We will suggest go out and have a conversation with an insurance specialist about this, who can take a look at everything and see if you're eligible. I mean, the premiums, people get nervous because it's, you know, all the information they hear out there and all the issues of long-term care insurance, that the premiums are expensive, but they're dictated by a lot of different factors, including your age, your health. There is medical underwriting, so really important that you get it sooner rather than later, before a health crisis hits, and perhaps it's going to knock you out of the box and you won't be eligible. The amount of daily benefit, the elimination period, and the inflation rider. Different types of policies that are out there now. There are the straight insurance, like long-term care insurance policies that will pay a benefit. There are hybrid policies, which are life insurance policies with a long-term care rider on it, which makes it much more palatable for a lot of people, much more affordable. And for people who say, "Hey, I'm never going to need the long-term care insurance. My kids will put a pillow over my head. I'm not going to need the care." We hear about that a lot. But so if you pass away and you never use a long-term care benefit, well, it'll pay a death benefit to your heirs. So it's not like you're just throwing your money away. There is a New York State partnership policy that will allow you to go on to Medicaid in New York after you exhaust the policy benefits without worrying about your asset levels. I have this bullet says 5 years of coverage because let's say you want to come to see somebody like me to do some asset protection planning. You could also say, well, what if I don't get past that Medicaid 5-year look back or the 2.5-year look back that we're going to talk about in a couple of minutes? Well, get a policy, keep it for 5 years. That's like a guarantee that the great estate planning we're going to do for you in long-term care planning is going to work in the event that you perhaps need to tap into that coverage sooner rather than later because you suffer a health crisis and need significant care. So that coverage can include skilled nursing, assisted living. You can use that coverage to pay for the room and board at the Bristal, for home care with caring people, and the other types of care that's on that slide. So again, talk to your insurance professional about that, and they'll be able to review different types of policies and compare them and look at the different premiums. Next slide. Again, as Julie mentioned, there are VA aid and attendance benefits to veterans who meet certain service requirements. It's a non-service it's a benefit that doesn't mean you were totally disabled or whatnot. It's a service-connected disability requirement. There are stringent income and asset tests. It requires planning in advance of needing the benefit. So it's available to veterans and to surviving spouses of veterans. So again, it will pay a cash stipend if you meet the requirements, which again can be used for care. It could be used to pay for assisted living, and something that's very valuable to look into if sometimes you can tap into that benefit, use your other income as well, and that might bring you and be able to pay for the whole cost of care that you need. So important to look into that as well. Next slide. So now we're going to get into the payer of last resort. There are two major types of Medicaid in New York, community Medicaid and chronic Medicaid. But for purposes of tonight, since we're talking about keeping you home, ideally, and the type of Medicaid program that we tap into primarily in our office for our clients who need it is the community Medicaid program. So that is to provide coverage essentially for home care. So for the cost of aides to come into your home and care for you, and for assisted living. If there are assisted living programs, and I know the Bristal does participate or will participate, I think, in the Medicaid assisted living community program. So again, there are stringent income and asset tests that must be met. Right now, there is no look back period for community Medicaid. That is going to be coming to a screeching halt, and we're going to talk about that on the next slide. So very soon, on April 1st of well, there's a typo there. I just saw April 1st of 2021. That's going to start a new look back period. But either way, there's still going to be stringent income and asset tests that must be met for someone to become eligible for the program. So these numbers change every year. I wouldn't get very excited. They change they're very slightly adjusted with if the cost of living increases. So a single individual can only have about $879 a month of income. That's the spouse who needs the care. The other spouse, the non-applying spouse, can keep about $3,260 of income. On the asset side, a single individual can only have $15,750 of assets. So that is not a typo, that's the actual number. And the community spouse or the non-applying spouse, somewhere, let's say between $75,000 and $129,000 of assets. And I know what you're all thinking, how can I possibly live on Long Island with that amount of income and assets? Well, we need to talk about planning in advance to protect as much as possible to become eligible for this program. Next slide. So like I said, the program is changing very quickly. So the phase-in is starting on April 1st of 2021. Originally, it was supposed to start January 1 of 2021. The look back period would start, but because of the public health emergency, that was pushed back. So it's going to start April 1 of 2021. So for any transfers of assets after October 1st of this year will be subject to penalty once applications are filed from April 1, and that's probably good. It's not even an April Fool's joke, I want to say. It's actually any transfers made on or after October 1, if you apply for Medicaid starting April 1, 2021, will be subject to penalty. So any transfers, the good news is any transfers that you've made on or before, you or your spouse on or before September 30th this year are totally exempt. So it's not going to create a problem. And because the phase-in of the look-back period was pushed back to April 1, it's giving a little bit more of a window period of time to plan and get an application in if necessary. So transfers between October 1st of 2020 and March 31st of 2021 should be exempt. So if you're on the cusp of needing community Medicaid, it's critical to see your elder law attorney ASAP to see if this could get in before the start of the look back period. So as of April 1st, those applications, it's going to go back, it'll be a 6-month look back period. So it's going to be April 1 back to October 1. Okay. So and then it'll increase 1 month every month until it's a complete 30-month or 2.5-year look back period in April, I think it's 2023. So the good old days of being able to transfer assets, let's say today, and become eligible tomorrow or next month is going to be over. So it's just going to make planning and so much more critical to engage in proper proactive planning. And the advocacy, as Ann was talking about earlier, is going to be essential. It's going to be key. You're going to need to hire someone like Ann to be a private advocate because of all the medical assessment changes that are being discussed, that are going to be implemented. You're going to need to be able to need more requirements with activities of daily living, more than 2. You're going to have to show that you need physical maneuvering. There's a lot that goes into this that we can't possibly touch on all of this right now, but there's going to be a new assessment tool that's used by an independent assessor to make a determination of the number of hours that you're going to be awarded. And no longer will your own private physician be able to sign off on the paperwork for disability. So the doctor that you've seen that's very familiar with your care, that's intimately involved with your life and your care needs and knows your case and is not going to be the one that's going to be signing the paperwork. There's going to be an independent medical assessment from an independent doctor that's provided by the Department of Health that's going to make that determination. And that doctor is not going to know you, not have a relationship with you, may not have the specialization in your particular condition. So there's a lot of changes coming down the pike. So, advocacy for the care needs is going to be essential. And planning and getting the right advice is going to be more important than ever. So a lot of these changes are being implemented because of budget issues. Very expensive, and we think they're trying to make more people have to go into skilled nursing rather than stay at home. So it's going to be ever changing and evolving, and there'll be more information to come that we will share with you. As things progress and we see how things play out. So that's really the biggest change in the Medicaid world right now is what's happening with the community Medicaid program. Again, you still have to become financially eligible. So in that 2.5-year look back period or a 5-year look back period for chronic Medicaid, if it ever gets to that, Medicaid looks at you and your spouse. If you're married, they're going to look at all of your income sources and total all of that up. So it's fixed and non-fixed income, Social Security, pension, annuity, veterans benefits, interest, dividends on all your accounts, and the required minimum distributions from your retirement accounts. I know this year people, with the CARES Act, they didn't take their RMDs, but if you're on Medicaid, you're going to need to take those. And then your assets consist of everything else. All the stuff that you own, your real property, your home, your bank accounts, brokerage accounts, the cash value in your life insurance policies. If you have term life insurance, doesn't matter, no cash value. And then your retirement accounts is an asset. However, if you're over 72 or even younger and you're taking your required minimum distributions, the principal balance in those IRAs, 401ks, whatnot, will not count as an asset. Really important to recognize. Those RMDs have to be taken properly. So again, that's just all part of the analysis and the assessment that goes into your financial eligibility. Next slide. Okay, so we all been talking about proper proactive planning. Obviously, we would never want to stop the aging process, but we need to make sure that we do the planning as, as proactively as possible. We see it two types of clients in our office. Those are planning proactively in advance of a crisis. So when they're relatively young and healthy, they could create their planning, they create the instructions, they can stay in control of everything, they can have access to all of their money. And when they're doing the planning, much less stress, frustration, aggravation on the part of the family, and much more that can be protected. Unfortunately, but human nature causes a lot of people to procrastinate, right? So sometimes planning is not done in advance. And then guess what? Then we have a crisis situation because, God forbid, you're in a hospital or rehabilitation facility. Guess what? You're not the one coming and meeting with us or meeting with another attorney. It's typically your spouse or your adult children, and they are stressed out and frustrated because now they got to put a plan in place. Okay. At that point, you're not in control. You're not going to have access to your funds, a lot less that can be protected, and so much more corresponding stress and whatnot on the family. So if you're on this call tonight, hopefully you're in the proactive planning category, but you might be on the call for someone who might need crisis planning, but it doesn't matter which one. We can help you with on both sides of it. Ideally, we want to educate people as much as possible about engaging in the right planning early enough, because again, you can stay in control for as long as possible. But we want to help you get the care that you need, help you put a plan in place to pay for that care so you don't become destitute, your family doesn't become destitute, and your children or loved ones or other beneficiaries are going to inherit at the end of the day, much less so you're not paying the government or whatnot. Next slide. So what goes into the planning? A lot of different elements. These are the main types of estate planning documents that we generally will discuss with you, or these are the type of documents that you will discuss with your estate planning or elder law attorney. Next slide. I want to break it down into the life and healthcare planning documents. And this doesn't go to paying for care, but just to recognize that having a really good sound healthcare proxy, your end of life decision making, which will have your do not resuscitate, do not intubate orders in it. That is all HIPAA compliant. The most is not a form that we get involved with. That's what you would do. You would prepare with your physician at end of life. And a personal care plan is something that we prepare for our clients who are interested, which is a detailed set of instructions that go to quality of life, that talk about what kind of care do you want if you can't indicate what it is you want at that point. A lot of people with dementia or Alzheimer's don't remember what they like until it's put in front of them. So it goes to maximizing quality of life, a set of instructions that can be given to a caregiver that will address it. So as we want to help to maximize your quality of life and get you the type of care that you deserve in the setting that you want to receive it in. Next slide. So some of my favorite documents here on this slide as well are some of the legal and financial planning documents. Everybody needs a good, durable general power of attorney, which is going to give somebody else legal and financial authority to step into your shoes if you become incapacitated. So that is something that's really important. We expand it, we modify it, we put in a lot of powers in an elder law, elder care context. So somebody else can help to get you the care that you need. We'll be able to pay for the care that you need. We're not going to really talk about the will tonight. What I want to focus on is a special kind of trust that we use to protect assets for Medicaid planning purposes. There are three main types of trusts that we generally discuss or talk about in the office, depending upon what your needs are, what your planning needs are, what your goals are, because everything has to be customized and designed around what you're trying to accomplish. Next slide. So First type of trust, which you see on the left side of your screen, is a green open box with the letters RLT in there, stands for Revocable Living Trust. I call it an open box like this because whatever you put into it, you could take out. You stay in total control of the assets. You can receive all the income generated off from the assets, and you can get all the principal that you want. So guess what? If you need care and you wanted to apply for Medicaid, is this trust going to work for you? Absolutely not, because whatever you have access to, so do what I call your creditors and predators. So it includes Medicaid. So Medicaid's going to say, well, you've got to spend everything down in that trust first. And way after you do that, come back, knock on our door, and we'll talk about, covering you. On the far side, in a closed blue box, is a typical irrevocable trust. Those trusts are used, we're not going to talk about it tonight, for people who principally have an estate tax issue. They want to get assets out of their names for estate tax purposes, so they're paying less to Uncle Sam at the end of the day. But that one, you're going to lose all control over everything, not something we're going to talk about tonight. In the middle, it's kind of an orange colored, and it's not totally open, it's not totally closed. It's a hybrid trust, somewhere between the revocable and the irrevocable. It's still irrevocable for Medicaid purposes. But once you put assets into this trust, so let's say you put the principal in there, like your house, let's say you put your house and $200,000 into this trust. Okay, you name your adult son and adult daughter as the trustees. Okay, once you put the money in there, okay, it's going to be out of your control, basically. There's some couple little things that you might be able to do, but basically you're giving up control, but you're naming trustees that you trust to be able to manage this property. So the whole purpose is to get them out of your individual name so that when we look at the financial eligibility thresholds, you can meet those requirements. You can get income out of this trust if you need it to help you pay your bills while you're living in the community. That's okay. If you go on to Medicaid, the income generated from this trust will count toward the income thresholds. So let's say you put your house in this trust, you get to live in the house. You retain the ability to live in the house, and you get to pay all the expenses. So you're not going to feel any different. You use your other money that you keep out of the trust to pay for the maintenance and upkeep and taxes and all that, and that's perfectly fine. If you put $200,000 into this trust as well, you can't get the principal out. So let's say you have your house plus $200,000 in the Medicaid Asset Protection Trust, you have $100,000 in the Revocable Trust or outside of that Medicaid trust, you spend all the other money down. What do? It's okay. You can tell your trustees to make a principal distribution to beneficiaries that you name in this trust. Generally, they're adult children, they're good kids. They're going to take that money and they're going to either use it for you or give it back to you if you need it, and that's okay. So there's a mechanism by which we can get access to the money if we need it. We just don't want Medicaid to be able to, so the trust has to be designed a certain way to protect the assets. So Medicaid, we get past those look back periods, because these will trigger the look back periods, 2.5 years. We look forward 2.5 years or 5 years. If you fund the assets in today and you don't need Medicaid home care and you don't need skilled nursing care for the next 2.5 years or 5 years respectively, and then you go to apply for Medicaid after that, everything in this trust is protected. And then all other things being equal, Medicaid will start paying for your care. So this is the Medicaid Asset Protection Trust, the MAPT, is the principal vehicle we use to protect assets for Medicaid planning purposes. We typically don't give the assets away to those good-for-nothing kids who are bothering the heck out of you, as Julie was talking about, not because we don't love them, but, there could be situations where, unfortunately bad things happen to good people. You're taking your protected money, you're giving it outright to somebody else, and now it's subject to their predators and creditors. So you give it to your son, you have that $500,000, you give it to your son, he gives you a big hug and a kiss, and the next day his wife serves him with divorce papers. We got a problem, right? So there are better ways to protect the money. So it's there if we need it. It's there if we have to get it back. So obviously I'm giving you a very high level overview. There's so much that gets discussed in connection with creating trusts and designing them and funding them. You can go to the next slide. Yeah, so this is just to show you that it's really the Medicaid Asset Protection Trust, which is the principal planning vehicle. But in anything we do, and as you can see today, no, not one person can do everything. So if you ever go to see an advisor and that person says, oh, I can do your legal planning, I can invest your money, I'm going to do your tax returns, I'm going to do everything, you probably should run out the door. So we want to collaborate and work together, because when everybody is doing their piece and working together, you're going to get the best strategies and solutions and advice that's going to meet your needs and objectives. So the team approach is essential and critical to everything that we do. And I have social workers in bold because I think social workers are amazing. We need them. They are instrumental in everything that we do, in terms of trying to coordinate the care that you're going to need wherever it is that you're going to get it, hopefully at home or at the Bristal. Next slide. So just a few tips. Please plan as early as possible. Be proactive. Again, we talked about working with a good team of advisors. Anybody here, you should reach out to. They are phenomenal. Whoever you meet with, whoever you work with, you need to be honest. You need to put all the issues on the table, because if you don't and you hold back, there are a lot of things that could be missed in terms of creating the appropriate plan for you. Really discuss all the options, look at all the funding options, look at all the care options, look at all the possibilities. You know, it's not a one size fits all for people. You have to look at all the possibilities and make the best choice possible for you. And that those choices may change over time as your health and your care needs change. So implementing a holistic, integrative legal care plan is important, you know, not just focusing on the legal stuff, but being, you know, holistic and looking at the care needs has to come first. And then monitoring and updating that plan is necessary. So planning is not a one-time event. Your planning is going to change again as your health, your wealth, your family, and the laws change. If anybody ever hears about the laws changing, I never heard about the laws changing, but it happens all the time. So that might affect your planning, just like the Medicaid laws changing and the rules and regulations. So we want to constantly be working together and monitoring, maintaining both your care plan and your legal plan at the same time. So that will be essential to making sure that the infrastructure is going to work for you. Whatever plan we put in place for you, we want to make sure it works for you when you most need it to work for you. So it's not done in a vacuum, and it's not a one-time event. So I will end there. I don't think I have anything else. It's blank. You see, I don't even have that closing slide. So thank you.
Thank you, Wendy, so very much. So that was very informative, and we have a lot to think about, everyone. There's lots and lots of really, really important information that I'm hoping everyone is going to mull over and think about. In the meantime, I know that there were some questions in the chat. Pam, if you wanted to, you guys open to questions? Julie, Wendy, Jen, Ann? Okay.
No, I'm not open to them at all.
So everything that's asked to Wendy, we're not asking.
No.
I think
Very simple.
I'm going to have dinner. I'll see you later.
Okay, the first question, and I think you answered a lot of it, but what is community Medicaid?
Okay, so I think we answered that.
And that's for Wendy.
Yeah. Well,
I mean, just briefly, in a nutshell, it's the Medicaid program that's going to cover all or a portion of the cost of care in your home, basically.
yeah. Okay.
Okay, the next question is, again, for what, I guess, how can one decipher between the various long-term health insurance policies to decide which one is best and at which age to buy, at what age to buy?
I have no clue.
Maybe
No,
Ann?
I mean, serious. In all seriousness, I mean, that's why I say you really should work with a good long-term care insurance professional.
Mhm.
And if you need referrals, you know, all of us work with them. So we can, you know, there are probably some people that we would all refer to. So if you need that, just reach out to one of us. But that's there. It's very difficult to decipher those. I don't do that myself. I defer and, you know, partner with other, you know, advisors. So again, there's so many different factors that go into it. So working with someone who's going to, you know, give you a spreadsheet with and break it down and show you a comparison of all the different policies and the premiums and the benefits is really the best way to go about it. I mean, again, getting it as early as possible. Usually the rule of thumb is 50 and up. Most people don't look at it younger. I did because of my son, but you know, for most people, they look at 50 and up and look, you know, it's usually after they've paid for other expensive things in their lives, like college and things of that nature, when they may have free up some money for premiums. But again, you want to get it before you, God forbid, suffer, you know, a health condition that will preclude your ability to get it. So usually the rule of thumb is 50 and up.
And maybe you guys, you could give us a couple of the names to
Yes.
Pam and I, and certainly we can also pass that information on.
Yeah, I would appreciate that.
Absolutely.
Right, thank you.
Here's another one for Wendy. I've heard of Medicaid waiver programs like NHTD, but most people seem to not know about them. Why might that be?
NHTD.
Good question. I'm not sure. I mean, it's not the mainstream. It's not what most people are, you know, are looking for, but it is out there too. It is an option. So it just has to be something that's looked at. But usually if you go to your elder law attorney or estate planning attorney, they will, you know, if you meet certain requirements, looking into that waiver program, which is a huge benefit. And sometimes that will work where the straight Medicaid will not. So it's a little more specialized. I think that's why. Otherwise, I'm not sure how to answer that.
Any other questions, Pam and chat? Okay. Anyone have a question where they just want to, Estelle, do you have a question? Take yourself off chat.
Mute. Okay.
Go ahead.
I'm just curious, if all of your assets are in time of death to go to your children and they have divorced, are their wives entitled to it?
The great question. We would never want it to go to the daughter-in-law, right? No.
No.
That would be the worst case scenario. Oh my God, never, never. Unless you're my husband, in which case he doesn't have a choice. But,
So in other words,
no, I mean, there's ways. I understand where you're getting. I'm just joking. So if you structure the planning properly, it should never go to an in-law unless that's what you want. So typically it would stay in the bloodline, and you can protect it by leaving the money in trust for your children. So
Yes.
that if the next day after you die, you know, things aren't done properly, it's in that trust for your son. So all he needs to say to the, you know, the crazy daughter-in-law who's serving him with divorce papers is, oh my God, my crazy mother set up this trust for me. So, you know, I can't access that money. Sorry, you don't get half of it.
Okay, thank you.
Someone else want to ask a question? You're welcome. I'm trying to go around here, trying to do this. Just raise your hand, or this is when shouting out is the way to go. Anybody? I know it's a lot of information to try to absorb. Okay.
All right, you said, Gloria, you said that you recorded this, and I could see it on the right-hand side, and you said if anyone else wants to listen,
Yes.
how do they get onto it?
It will be on our website, and literally there's an arrow that you have to press and it takes you right to the recording. We already have, if you look at our website carefully, which is why I said, please go to the website. If you check the chat, I have the link to our website. We have most of the webinars and presentations that we've had are recorded and are on our website. So a lot of the ones that we've had for Parkinson's, the ones that we've had for Pam's programs or dementia programs, and this one as well, they're all being recorded for future use, or for friends or neighbors or anyone you think would benefit from it. So just,
Caveat to that is anything we said only applies to tonight. If you watch it 2 years from now, it doesn't. You can't hold us to it. I'm just saying.
Right.
I'll remember that. All right, everybody. All right, well, thank you so much, first of all, to our amazing panel, Wendy, Julie, Jennifer, Ann. Thank you so much for all that information. We're all going to be thinking and studying, I can tell you that. And just the rest of you, thank you so much for joining us for this presentation. We are hoping through the year to keep providing you with as much information as we can. So keep on the lookout. We have a couple programs coming up tomorrow night. We have our Parkinson's caregiver program. We have a support session on Thursday. And then of course we have our Friendathon is coming up, our 8 days of giving. So please look on our website. We have some amazing stuff coming on. So I hope to see you all soon. Have a wonderful night. Bye, everybody.
Thank you. Thank you. Thank
Come on.
you.
Good night, everyone.
Thank you.
Bye, everyone.